So thank you for joining.
So it's now just 12:55.
Yes, and I was going to say exactly that. So perhaps it might be worth starting so that we have a little bit of time to actually discuss, if you'd like, obviously, or ask any questions. It would be wonderful to know who's actually here as well, so that I may be able to kind of pitch or provide further details that may be relevant to you and your role. So my name is Maria Bourbon. I am a mental health nurse in terms of background, with quite a lot of experience, first of inpatient units, but afterwards in learning disabilities and in autism. I've set up several services, including the diagnostic and treatment service in Oxfordshire for young people autistic, and also more recently Keyworking, which is part of the NHS long-term plan in terms of young needs. If that's okay, I'll just go around the screen. Joanne?
Hi, I'm Jo Robinson. Oh, sorry. It's Joanne Field as well, isn't that? Sorry, I was thinking I was getting my full Sunday name, Joanne. I'll speak now. Sorry. I'm Jo Robinson. I'm preparation for adulthood and SEND lead for adult social care in Tameside.
Wonderful. Thank you very much. Shall I go to Joanne then? The other Jo.
Hi, I'm Joanne Field. I'm one of the clinical leads and children and young people's transforming care in Bradford for the West Yorkshire ICB.
Thank you very much. Stephen?
Yeah, I'm Stephen Booth. I'm the SENDIAS manager in Salford, but I'm also the transforming care manager as well.
Okay, wonderful. Thank you very much, Stephen. And Corinne? I hope that I'm pronouncing your name correctly.
Yeah, you are. I am an early help team manager in social care in Cornwall and sit on the board for our local Keyworking group, but only just. I'm part of the disability team.
Wonderful, thank you. And Kate, I know that you initially, I don't know if everyone already knows who you are.
Yes, Kate Thomas, and I work at NCB in the health team.
Thank you.
I'm just helping out today with the logistics.
Thank you. And finally, Zoe, is it all right if would you mind just introducing yourself?
Of course, yes. I'm Zoe Delfield. I'm one of the deputy designated nurses for looked after children at NHS Kent Medway for the ICB. My previous role, I was a deputy DCO, and moving into this part of the team, I'm still signing off all the health elements in EHCPs for looked after children to try and ensure their pathway, where they can be quite transient, still, goes smoothly as best it can. So yeah, that's why I'm here today, because you don't often get many looked after children's nurses here, so that's the rationale.
Thank you. And Marie, would it be helpful for you to introduce yourself as well, just to have a bit of a feel of who's here?
Hi everyone. I'm Marie. So I can't get my camera to work because I'm out of the remote desktop, but I'm just kind of I've just finished my own workshop, so I'm just popping around all of the other workshops to see how they're all getting on. But I hope you're enjoying the day so far.
Thank you so much.
I'm Maria. You didn't let me introduce myself.
Miranda, I'm so sorry.
It's okay. I'm Miranda Walcott, Designated Clinical Officer for SEND for Berkshire West ICB and Clinical Advisor for Children and Young People. So I also have the Key Worker project in my portfolio as well.
And you're also kind of the wider ICB, and I'm sure that we'll see each other more often. So I'll just kind of share my presentation, if that's okay. If this. Right. So So today I was hoping to talk about Keyworking in Oxfordshire. We are one of the pilot sites nationally, although this is now being rolled out across the country. So what is Keyworking? Well, Keyworking has been born out of Dame Lenhan's This Our Children report, which highlighted how young people who are autistic and or have learning disabilities are often stuck in the middle of processes that do not quite understand their individual needs, and where actually their wishes and wants for both them and their families are not really considered. So kind of really being stuck on process and rather than thinking a little bit outside the box. And we know that often these young people have very complex needs. So that multi-agency working is particularly difficult to achieve, but most importantly, it's a nightmare to navigate for the parents and the young people unless you have a degree. And even like that, it can be a full-time job in itself. So we were initially called a key worker team, but actually that was creating a lot of issues. So we went out there, we asked our parents and carers and young people as well as other professionals what would describe better what we did. And this was the name that they came up with, is the Autism Learning Disabilities Liaison. Because that's very much our role. I would often describe us as being between the different. We don't really replace everyone, but we really facilitate that different people come together and identify them. Our logo was also designed and chosen by. So as a team, we are not a very big team. There's a service manager, and currently I'm fulfilling the dual role of being both service manager but also team. We have 4 case managers, 2 social prescribers in them. So in terms of roles, the case manager is usually someone quite senior who is able to kind of really deep dive into the history of the young person and try to understand what the needs are. I've just heard things, so I don't know if you can still hear me.
Hi, Maria. It's quite quiet compared to other people. I don't know if you can get closer to the microphone.
I'm going to try. Let's see. If you can see me too big, please do let me know. So the case manager, as I was saying, is their role is very much about kind of looking at the young person holistically and go through their journey, trying to identify what is already in place, what isn't, what has been tried, what hasn't, link with the professionals to try to have their own views, but also then linking with the family and the young person to really try to understand what is their perception of what's going on, what are the difficulties, but also understand what is their goals and aspirations. We have a social prescribers in our team, which their main role is to think about not just keeping to the statutory services, but also thinking what is out there in the community that young people want to be linked with and would be a good match. Often they become involved when cases are no longer in crisis and people are in recovery, but actually really depending on what it is, it can be. And obviously, like in any other team, our administrator is the glue that binds us together, and without them, we wouldn't be able to do anything. So I now have a diagram that kind of shows a bit of where we are positioned. So we hold the dynamic support register on behalf of our local CG, and that over there we should have all of who are at risk, and we are now in the process of establishing kind of a review that is also agency. The reason why we chose to hold that information was before there was a dynamics register in place, but actually the way that people were grading wasn't consistent regarding what was needed, and therefore by just having our team who is always involved with the high risk cases, we ensure consistency and adequate step down and step up as needed. So obviously we have links from inpatient to crisis team, but increasingly also with social care, children's disability services, children's continuing healthcare, and obviously education is a large part of what. Although we are embedded in health, I often kind of say to people that this is, we sit above because our co-signatories are also the local authority and parent care authority. So just talking a little bit about kind of some of our innovations and successes. So obviously we have the DSR, and I think that has been extremely helpful because the way that we rate risk is very much multidimensional and holistic. So we rate the mental health, we rate kind of social circumstances and also education. And the reason why we do that is because actually from a mental health point of view, the young person might not be at immediate risk of inpatient admission. But for instance, if they are not in school or school is breaking down, and alongside that, the parents can't cope and are saying, actually, we need either respite or, yeah, I would like my child to be taken into care, their mental health is going to be affected very, very, and we don't want to. We have personal health budgets in mental health, and I was hoping that my colleague Jenny Bransby-Meehan would be join me today. And personal health budgets have always been present, at least in Oxford Health, for physical health or for children with very complex learning disability and autism, but not for young people that don't quite meet that threshold. But we also know that is, in terms of the numbers, at least in our local area, those who are at a high risk of admission and inappropriate psychiatric admissions are those who are high functioning. And by that, I mean are clever and intelligent and tend to internalize a lot of feelings, and their autistic needs not being met come to the forefront through mental health issues. So having equity of access has been really helpful. So we established a pilot for mental health budgets within our team, following the same principles as in children's continuing healthcare. We adapted a tool to reflect what symptomology would be in mental health, so that the values that would be given in terms of the budgets were also equitable. Obviously, a lot of our units not need assistance 24 hours a day in terms of breeding, but actually they might need supervision because their risk taking is. So that's kind of the type of things that we would. Our social prescribers have been amazing at going out there and really mapping out the different services available. And we now have a really good comprehensive understanding of what's coming out there, but we also have a really, really good understanding of what are the strengths of each of the organisations, what is their perhaps their thresholds in terms of behaviours, what they are able to offer or not, and we really try to make a very good matching. So just to give you an example, we found a wonderful program of coding, so it's ninja code breakers, and young people don't need to have an autism diagnosis or an LD diagnosis in order to access, but actually the group tends to be small. Young people have very strong focused interests, and it tends to be very structured, so it works very well for our client group. Kind of following on from that, and I know that other sites nationally also are using the Star. So this is a holistic way of measuring outcomes that kind of measures, not just in terms of health, but it might talk about sexuality or meaningful relationships, finance. So we kind of really look at the young person as a whole. And although, you know, we might target particular areas at one stage, we want to see differences throughout wherever possible. And finally, I think that this is what is really important, is that, you know, we have seen a significant of inpatient admissions at one stage. So we have had no inpatients in 22. So unfortunately, we had a couple, but since then, mostly out of hours, in which we weren't able to do anything because some young people do come out of the blue. Thus, the reality is that some very well, and then there's a trigger, and things just happen, and they're very quickly gone. But nonetheless, we've had already a significant impact in terms of actions. So I think that there is this kind of side in terms of what is it that we are able to do directly, but what are the other things that we are able to do directly just because we exist? So in terms of commissioning, because we are on the ground, we can understand exactly what are the gaps in services. So for instance, in Oxfordshire, as a lot of the southeast, there's very limited provision in terms of housing for young people. So when there is a breakdown in the home, often young people end up hundreds of miles away, where actually they are out of sight, out of mind, and actually they are disconnected from their loved ones, and they should be in touch with their families if possible. So we are currently working with our commissioners on different bids and different specifications to kind of meet the needs and most importantly reduce the need for unregulated placements, which unfortunately are. We are also working with social care. So for instance, we are looking at a training package for social workers and systems to ensure that when placement requests are sent out, that they are written in a way that reflects the views of the agency, but they are much more person-centered. And I don't know if there's any, I don't know how many of you have been involved in placement requests, but or have assessed any, but often you would see the needs and a long list of incidents related to a lot of our young people. And actually they are more than that. A lot of the times the incidents that they are involved are in response to lack of adaptations or the right systems around them. So it's really important to have. And I think that as part of that, because we are describing the need and better, we can then have better offers regarding matching, but we can also support social care with ensuring that they are asking the right questions. In terms of camps, again, one of the things that have become apparent is that the knowledge in terms of autism is very different depending on the team that young people have. And as part of that, we undertook an audit that identified particular themes and now looking at developing training packages and particular tools for clinicians to use to be able to work and think much more multi-agency. And finally, we are looking at better governance and accountability systems. And I think that part of the issue has been that often between agencies, we might come up with solutions that don't really take into consideration patient voices, but not just that, there's the navigation on how to challenge that hasn't always been the case. So just kind of as a final thing, I wanted to just talk through a case study to give you a bit of an idea of what actually does this all mean in practice. So we had a 14-year-old girl who was confirmed as being autistic at age 8. She had a history of inpatient admission for an eating disorder, self-harm and quite risky behaviour. At one time, she had set fire to a mattress in the house. She had had a specialist school breakdown, and things kind of fell apart very quickly. She had to return home. No new placement was identified despite extensive search. Mum had to stop working. I'm sorry about that. She had to stop working together because she had to be to look after life. And there were also other children also have diagnosis of autism and or ADHD, so, and with very, very different needs. And although there had been a kind of involvement from CAMS, social care and education, there was no real clear strategy or long-term vision of where people wanted to be at, and the system was very stuck. So what did we do immediately? So we looked at kind of the gaps, and the immediate request was to change the team in camps, because actually there was no, where they were, actually they didn't have the right kind of resources to provide it. So they started having outreach input, and we also reviewed all the work undertaken and the documentation. For the family support, actually the communication was very poor. Different people were saying different things to the family, leaving them quite confused. I think that everyone was giving their own kind of view of the difficulties, which often didn't match. So again, there was contradictory information, and therefore we identified one person that would have that communication consistently with the family, which initially was just us, but then obviously we kind of encouraged others to kind of step up. We requested an assessment of family needs, including of siblings, and we sent placements to ensure that that true representation was there. And then we also kind of had regular professionals meetings with action tracker, and because there were particular issues, the case was escalated to a case panel, and the local CCG safeguarding, and the social care director was asked to oversee issues. So as obviously things started moving on, the young person expressed wanting independence, and therefore we were able to identify a placement. However, they didn't have autism specific understanding, and therefore we kind of were able to secure an add-on of a PBS specialist who was actually able to really very good relationship, and we also monitored the progress. There were concerns afterwards particular placements, so we were able to then move the young person to closer to home, and they are doing very well. From a governance point of view, the concerns about professional was escalated and changed, and then we had regular placement to ensure that the young person's goals were being worked towards, and they didn't really want to be with CAMS at all. It was the one thing that the young person said they didn't, and therefore CAMS just pulled out. They were there to support the rest of the agencies and provide kind of input from a more psychologically driven perspective, but don't have to work directly with people if everyone is able to understand the need. And as I was saying, the placement was home, the staff working, delivering a therapeutic environment and supervision, and because the parents were fully involved and feeling that the needs were being met, they were not chasing for updates, as they were able to trust the professionals that the actions were actually happening. So although at one stage there were numerous complaints filed against numerous agencies, that has really. So where are we now? young person has come out as transgender, so he is now kind of able to introduce himself as a he. This has been fully accepted by everyone. They had complete sleep reversal, and now the sleep is regular. They weren't able to eat in front of others, and they are, which I think is quite amazing. The parents are actually parenting rather than being lessons carers, and they have regular contact. Started college last week. They're absolutely loving. I think I was actually singing upon returning, and on top of that, he has reconnected with the friends that he had lost contact with, and he's actually traveling on his own independently. Mum is working, and when I make contact with her, she often says that, oh, it's okay, and she doesn't really hear from me. So this is kind of my pit stop on kind of Keyworking. I've stopped sharing now, and I was just wondering if you have any questions.
If people would like to unmute and put on the... Oh, I think Stephen has a question. Go ahead, Stephen.
Hello, Maria. I'm from one of the pilot sites as well, up in Salford in the northwest, and we've had some real successes with the Transforming Care Key Worker project. We're looking now at it going to a GM-wide model, so Greater Manchester model. One of the things that I've been a little bit concerned about is the success of the project has been because it's very specific to Salford and what Salford's needs are and what our population's like and how our services work with each other. And I just wondered if down in your part of the woods there's any sort of look at linking it into a bigger framework, and do you have any thoughts if that's positive, if it's negative?
Yeah, well, I think that's a really interesting question because, you know, on one hand, you need to have systems which are easily replicated, but on the other side, the reason why we work is because we are really specific, and I think you need to have that flexibility. I think that's part of it, and this is why I think it's everyone's business, and you need everyone to sign up for. Unless you have those tie-ins at the different levels, it's just not going to work. So you're absolutely right. You know, you tailor the service to the specific areas, but I think that there's some key pillars that need to happen everywhere. So I think that one of them is of governance. So for instance, I report not only to NHS England because that's our funding stream, but now I also report to the SEM board that meets every other month. I report to the local authorities directors, and I come and visit every month, in which I'm able to not just highlight the things that are going well, but also highlight the things that are going less well in terms of systems. And I think that the other thing is that we've created really clear escalation processes, and identifying who are the different people in is extremely important. And then finally, I think that there is something about people just having the time to go out there, making themselves known, and creating those relationships, because there's nothing like that direct relationship, as you highlighted as well, Stephen. It doesn't, people are so much more likely to do what you'd like them to do if they know you and if they trust you. And I think we had to work really hard. We are in a very different place now, but we have huge issues across all organisations with staff turnover. We know that statutory services are a really difficult place at the moment. The caseloads are huge.
I think we were really lucky in Salford because the SENDIAS service here is so established and well known that we already had those strategic links into different organisations. So when Transforming Care sort of started, we already had that credibility that sort of piggybacked on the back of that, and it was really helpful when we did need to escalate things and we knew who to go to, and we already had that. Where I've spoken to some other of the pilot sites who've really struggled to get those inroads into it, and I think you're right, it's about making it people's business, isn't it, and saying this needs to be on the agenda and it needs to be a priority. And I think one of the challenges can be that there's so many things on the table for people to say are a priority that it's just seen as something else, or actually it's a very specific intervention and needs to be seen and given that time. But I'm sure you've been part of the community of practices around it, and I think the work that's going on along across the country is just really, really encouraging. And I think it's going to have a massive, massive impact on those families that we work with. So it's just really always really good to hear other services that are, how they're working and their successes. So good luck with everything.
Thank you. So one of the things, Stephen, I think that our pilot site was probably less fortunate in terms of those relationships, and part of it was because Oxfordshire was undergoing huge restructure at the time. So we lost our commissioner, who was a real driving force right as we launched, and all of the directors in other agencies except for health changed as well. So we had to literally start from scratch, and I think that then it's about finding who are your allies and just being willing to keep on knocking people's doors. I can see that my colleague Jennifer Bransley-Meehan has actually joined. She's the team manager for the Children's Continuing Healthcare in Oxfordshire, and who has been absolutely key with continuing to drive our agenda. Jenny, I don't know if there's anything that you would like to add.
No, I joined late, so I missed part of it, but it's just really, it's really good to hear the extent of the project, and also, Stephen, I think to hear your experience as well, and to know that that this is happening in other areas. Our main focus has been to develop personal health budgets, and we've made huge inroads now into mental health thanks to the pilot. And so we've developed a fair few systems now for both assessing and allocating within the world of mental health, and also developed services around how we can translate what's usually been allocations of hours and people into equipment and resources. So it's been really interesting to be a part of the pilot.
Thank you, Jenny. So just to give you a few examples of what, and it is still a pilot, so we're still trialing, rather than giving a pot of money to each young person, which I know that has been the experience in other areas. What we've tried to do is having a way that there's a clear rationale about the pot of money. It is based on need rather than because that's what people want. And actually, we've been quite inventive in the way that we have used it as well. So, for instance, one young person was having a provision during school days or school week, but because that was financed through education, she kind of got to school holidays and her week was really depleted, and actually what she needed was that constant input, and therefore we were able to finance that instead through the personal health budget, because that was what kept them emotionally well. And we finance things like the gym, or we have a young person that accesses equestrian therapy, because that is part of their interest, but equally has a huge health impact.
It would be really interesting to find out a little bit more about how you've done those personalised health budgets. Is there any chance I could drop you an email, maybe just to have a quick catch up? I know we're all busy for time and things, but
that's absolutely fine. I'm quite happy to do a Teams call if people want to know a little bit more about the systems that we've used and how we've extended the systems that we use in continuing healthcare to identify budgets. That's absolutely fine.
Do you want to put your email in the chat so that if Stephen wants to contact you?
I think that
will I be on the tracking?
I don't know if it is, given that this was organised by the Council for Disabled Children. We may not be able to see the tracking. Thank you, Stephen. So, yes, I think that one of the things that we thought it was really important was to, create a system that wasn't just based on a budget in terms of related just to our team. I think that the ambition would be, and obviously I know that we are not quite there, would be that one day, if we have really structured tools and we are able to demonstrate the impact, that actually this would be a system that could be expanded to other areas of mental health. Because a lot of our young people, we work mostly with young people at risk of inpatient admissions, and there's others out there also in need that we may not know. So it would be really great that in time we could capture those young people well, who hopefully, because they have access to such systems, they will never be at risk of inpatient admission or placement rate.
Thank you so much, Maria. We've now run out of time, so thank you for delivering the workshop, and thanks to everyone for attending. And also I've put in a link to the evaluation for the whole event. If you can fill that in, that would be great. Thanks very much then, everyone.
Thank you. Really useful. Thank you.
Thank you. Bye.
Thank you. Bye.
Thanks, Maria. I hope it seemed to go well.
Yeah,
I think there would have been more questions, but as usual, we were run out of time. Yeah. The only thing I found is your volume was very low, even though I was trying to turn mine up. It didn't seem to have much of an impact.
I'm really sorry.
I don't know if you've got. Well. Do you have headphones with a mouthpiece or anything? But I just wondered if that would be easier for future stuff.
Yeah, I was told that actually people can hear me worse when I have the headphones on. So
really?
I wonder if it might be with my computer or with the internet connection today, because I haven't been having